this opportunity to present. When I thought I'm going to talk about mood disorder, it was such a vast topic. And although I have made quite a number of slides, we don't actually need to go through some of the slides because some of the information is quite basic and may not be relevant. But we're here going to talk more from the clinical perspective. And myself, when I do a lot of medical legal reports, how it is relevant in terms of working out not only a diagnostic plan, but also working through a management plan and giving some direction as an independent psychiatrist on terms of their future functioning. So I'll go through some of those earlier slides pretty quickly because we don't need all that information. And I'm pretty sure you know most of it anyway. So let's talk a little bit about, I focused only on depression, but also the different kinds of depression in that setting, because that's the most commonest condition or mood disorder we get to see in our setting. And of course, you've got different variants of types of depression, causes of depression. And just in a nutshell, I'll just take you through that journey and how we do the assessments and how it helps as other, medical assessments and other caregivers to make some decisions. So we'll just go to slide number 3 straight away, which is the depression and presentation. When we talk about depression, there are a lot of myths about depression, and it's very important to go through the DSM criteria. So being depressed is different from having a depressive disorder. And generally, in a lot of literature and documentation, the two most important things that define depression, one is anhedonia, or the loss of interest in activities. You can feel depressed on different days, but when someone says, I have lost that interest in doing things, that's when the flags to draw to say that this is something going on. And it's also the period of time. It's something that goes on for a few weeks or even longer. And it can be essentially, you could just be depressed or having the depressive symptoms for a long time and continue functioning. In psychiatry, anything becomes a disorder when your function is affected. So there is a big population who can be depressed, who can have subsyndromal symptoms, but they're still functioning. It's when the functioning gets impacted, that's when it becomes a disorder. And so that's really very important to understand that. And then you've got different categories of depression. We say adjustment disorder, depressive disorder, and different kinds of disorder. I've also talked a little bit about some milder forms of depression. One of them is called cyclothymia, which is very hard to clinically assess it, but it's a milder form of a fluctuating mood disorder, which we call as a bipolar cycling. It has a brief hypomania and you'll have depressive states. So usually you'll have people coming when they're depressed, not when they're feeling high. Very hard to diagnose, but that is a precursor to leading to depression. So sometimes when we ask people about their pre-morbid or pre-existing condition, it's very important to ask them these questions because that increases their vulnerability to depression. Also, it changes their prognosis and their development plan. The other one is dysthymia. You'd see when we assess a lot of people, they say they've had history of depression in the past, they made recovery. It's very important to ask those specific questions that did they make full recovery? Did they have any inter-episodic symptoms? Did they have this feeling of, sadness, but they're still functioning? So that dysthymia is very important because it can be a chronic low-grade depression that can continue, but they're still functioning. And again, it has a poor predictor. We have a relapse of depression. The depression is more magnified and there's more function losses. So these are some of the pre-existing conditions that can impact your recovery and your prognosis.
Are you in?
And it's very important to keep that
Are you in Edge?
in planning future treatment. And then I've got a seasonal affective disorder. I don't think we really need to worry about that. This is something we see more in clinical practice where it is affected by weather changes and it is very unpredictable, but there's no treatment for that. So we'll go to the next slide.
Excuse me, Dr. Rastogi, just one moment. Please, everybody, out of respect for the other people listening and for Dr. Rastogi, would you mute your microphone, please? Thank you.
So let's go to the causes of depression. Can we move to the next slide? Talking about what are the causes. As you know, the cause of depression is very broad, and there's not one thing that causes depression. So briefly go through these things. Again, this is something to keep in mind when you're assessing for someone with depression, like a family history. If there is a strong family history, if there's one parent who's got that, the chance of you having depression is 30%. If two parents have it, the chance of you getting depression is about 50 to 60%. So there's a very strong genetic predisposition to depression and anxiety. Hormonal changes, which is what you see in women with premenstrual and perimenopausal, not very commonly described, but it can be a cause when a woman comes in their 50s or in their 20s. We do ask about whether there is any premenstrual dysphoria or there is perimenopausal symptoms. Again, it can have an impact on the recovery of depression and the outcomes, and this can be a comorbid factor. Chronic pain, I've highlighted that because this is something we see all the time in clinical presentation, in reporting, where we are asked to make some prognostic formulation in terms of the prognosis of depression, in terms of the outcomes. And we really need to understand, and I've got a slide later that talks about the bidirectional association with chronic pain and depression. And it's really very hard to assess that because they both are chronic and lead to very poor prognosis. In terms of assessing the functional capacity and treatment, it has to work synergistically. And this is some of the nihilism we face as a psychiatrist, because it is a multifactorial and multidisciplinary treatment, and it involves a lot of game players too in the treatment. Drugs, of course, play a very important part with depression. So if someone's using drugs like alcohol and other recreation drugs, alcohol is a big one. It can be a depressant long-term, short-term it's a stimulant. So long-term use of alcohol abuse and dependence can lead to depression or a chronic dysthymia. Very important to look at situation factors like bereavement, relationship breakdown, which is what we say you've got an adjustment disorder. There's a significant stressor that leads to a reactive depression, which is then leads to depressive symptoms. Trauma is a big one. There are different presentations of trauma: physical, sexual, emotional. And it is very interesting with trauma, working in psychiatry, that trauma can be repressed. And that is generally, we see that. Generally, I would see people who work like ambulance, in the fire brigade, policemen, they can be exposed to life-threatening trauma for 6 years, 10 years, and then they present with PTSD. You need to understand there can be a delayed onset PTSD and depression because they self-medicate through different ways and they can manage to cope. So it's like a reprogramming in your brain where you can suppress the trauma, repress the trauma, you can use self-medication and still function till the penny drops or till you have your emotions being depleted. And that's very important because generally it's asked, oh, they were functioning well for 10 years and now suddenly what happened? So it is a buildup of triggers where your emotional resilience is significantly affected. And that's when it presents, where your function again gets affected. So they can still function, but when they have a functional decline, that's when they're reaching out for help. So very important to understand the hypothesis and the association. We've got medicines and drugs. So there are some heart medications, cancer medication. Steroids play a very important part in mood disorders. Medical issues, thyroid can be a big one for mood disorders, especially depression. And sometimes thyroxine is given for the treatment of treatment-resistant depression. Personality factors, very hard to find that cross-sectionally, and in a single consultation, it's very hard to get an idea of how one copes, but there can be some flags that can lead us to find that out, and social supports. So life events, as you know, they play a very important part in the onset of depression, in the recurrence of depression, and maintaining depression. Can we go to the next slide? So why do we need to know the different types of depression? That's really important. A is first, you need to know the cause of depression in terms to plan your treatment, in terms to plan the outcomes, in terms to plan your prognosis. So you have different types of depression. One is unipolar depression, where you have just depressive relapses from time to time. One is bipolar depression. As the name suggests, you can have mania or hypomanic symptoms with depression interspersed between depressive episodes. You need to remember, people with bipolar depression present with depression, but they will never report their mania or hypomania because it's a great feeling. So that is something we need to ask. Generally, some of the pointers to a bipolar depression is when someone has an early onset or adolescent onset depression, they're at a high risk of bipolar disorder. When there's a family history of bipolar disorder, when there are atypical symptoms of depression, or they've had a history of mania with antidepressant. So someone with depression comes and you give them an antidepressant and they become manic, the diagnosis straight away changes and the treatment changes. Very important, because you treat bipolar depression very differently to unipolar depression. Then you've got mixed depression, where you can have mania and depression, and this is very hard to treat, very hard to diagnose, and we need a few sessions before we can come to that diagnosis. You've got melancholic depression, which is how in the past we used to say you've got melancholy features. There's a lot of depressive cognitions, a lot of guilt, inappropriate guilt. There's a lot of physical changes like appetite. And this depression actually responds very well to mood stabilizers and antidepressants. It's actually a chemically derived depression. As you know, it's melancholic, internal depression without any external stressors. So it has a very good prognosis with treatment and pharmacotherapy and psychological counseling. Then you've got atypical features. You will find that sometimes with people with depression, they sleep a lot more, they eat a lot more, they describe a lead-laden body, and that's what it's called, atypical depression. Very important how you treat it, because if you give them more treatment that is more sedating, they become worse. So you have to acknowledge that, and the treatment program is different because that responds very well to psychological counseling and a lot of CBT. Then you've got psychotic depression, where, as the name suggests, you may have delusions, and you may have other negative symptoms, and that requires an antipsychotic treatment and as well as more intensive treatment. You've got peripartum or postpartum. There's treatment-resistant depression. The definition is if you have tried 2 or 3 antidepressants with partial remission, then it becomes a treatment-resistant depression. And then we go through the guidelines in terms of treatment using mood stabilizers, ECT, and transmagnetic therapy. And that is what is treatment-resistant depression. So can I just go to the next slide? I won't spend too much time in this. As I said, this slide is very self-explanatory, and there's nothing that all of you don't know what depression is. So the symptoms are, you could have physical symptoms, you could have anxiety or restlessness, you could have a mood disorder, or you could have cognitive symptoms. So depression has got physical symptoms, anxiety symptoms, you could have mood symptoms, and a lot of cognitive distortions. So we'll go to the next slide. Okay, I'll skip that one. This is again more for cognitive behavioral therapy. This is very important. A lot of people get stuck in depression with the cognitive patterns of depression, and very hard to shake them up. So the reason I'm bringing this up is very important, because if early interventions are not given, then you get into this depressive thinking pattern, which is very hard to break. So early diagnosis, early treatment can decrease some of these cognitive distortions and prevent resulting in a lot of impairments. And it's very hard. So when someone comes to depression for 2 to 3 years, they may not present with physical symptoms, but it's the thought. And these thoughts become very hard, become very entrenched to a stage that it actually then dictates your emotions and your daily functioning, and can be very difficult to treat even with cognitive behavioral therapy. So it's very important to think about that and understand, because this could be a poor prognosis for getting back into pre-injury functioning, or having any form of functioning ability. Okay, can we go to the next slide? So, as with any mood disorder or in psychological condition, the effect of depression, as I said, is we're not treating the person, we're treating the whole family unit or everyone around them. It has a ripple effect. Any mood disorder affects not only the person, but in terms of their family, the social relationships, as well as their work. So it is a domino effect, and it's very important to start at that person, treating that person early enough to prevent that domino effect. And very commonly, especially in women, it does affect children significantly. So if you have a woman with young children, it can lead to a lot of attachment symptoms in the children, and the children will generally have anxiety disorders and emotional cascade of mood disorders you're introducing in the younger children. So it's very, very important that the treatment is given, intensive treatment is given early on, and also provided some support to the family so that the children and other members of the family do get some help. As very commonly said, that it leads to relationship conflict and relationship losses through this journey very significantly due to multiple reasons, because of emotional detachment, anger, conflict, irritability, low self-esteem, burden. The list is endless. So it's very, very important that sometimes family counseling and support to decrease that and to maintain that family unit, so that and also there's stigmas attached to that. All right, next slide. Can we go to the next slide? Okay. I've actually brought this up very importantly because depression in men is very hard to diagnose. They're very hard to reach out for help, and the presentation is very different. So this is really very important because they shy away from treatment. They are not very open with their emotions, and they may present with other symptoms. So generally men would present with drug and alcohol issues, they may present with work issues or conflict at work, they may present with medical issues. And so the diagnosis of the mood disorders is generally through passive ways. They do not directly present, hey, I feel depressed. And at the same time, they're at a very high risk of suicide because of their poor emotional resolution and their ability to cope with things. So it's really important that when a man presents with depression, we have to keep that in mind, because they're at a higher risk of suicide, and their intensity of emotional distress is very high with very poor coping skills. Because it's basically related to their identity, it's their sense of functioning, their standing in the community, and to be told they are tough and they need to get on with life. So these are some of the challenges they're facing, because these are the formed belief system that has been basically inculcated in the brain to say this is, and so they struggle between feeling depressed and having those depressed emotions and what they expected to behave, causing a lot of internal conflict, and that can be quite intense. They're trying to surf their way out as to know, is it okay to feel like that? Is it normal? Oh, no, I'm just thinking. And that leads to a lot of ambivalence in treatment. So we have to be very careful how you treat them. And sometimes their personality factors come into play, which can be quite challenging. Next slide. Okay, I'll move through this quickly. So we just talked about chemicals in depression. That's mainly, we can move through that. So it's very important that depression often gets misdiagnosed if physical symptoms are present. Now, generally, I usually find that sometimes some doctors would say they've got a somatic disorder. And it's very, especially in the presence of chronic pain, I usually see that people will say, oh, this person's got a somatic symptom disorder. So somatic symptom disorder is hyper-focus on pain, and where pain rules, and they develop depressed symptoms. It's really important, again, at that time, to tease the symptoms of depression and to look for comorbid depressive symptoms when they have vulnerabilities, such as a physical vulnerability, or especially in the context of chronic pain. And generally, the depression will go misdiagnosed, and the focus will be on pain, and and that leads again to those distorted cognitive thinking, which is then very hard, because then they have a hypersensitization to pain, and there's a somatic focus on the pain, and they never get better. So very important to be mindful of that and keeping that in mind. Next slide. So what happens, I've been emphasizing all throughout, why do we need to treat early? Why do we need to diagnose early? So that's really important. If you've had your first episode of depression, there's a chance of 80% chance of recovery. That's pretty good. If you have a second episode of depression, it's a 50% chance, even with intensive treatment. 3 or more episodes, there's a third. That's when you're going into treatment resistance. So this is very important, that we need to get that early interventions in the first few months of the diagnosis with an intensive holistic treatment plan, keeping in mind the cause of the depression and treating it accordingly, so that we can get that 80% recovery and not move to the second and third episode or move to that stage. Yeah, next slide. So depression and pain, this is something, as I said, we come across a lot in clinical practice in terms of when you're doing independent assessments, and with having a multidisciplinary approach, it's very hard sometimes to know, because each one entity is giving their own expertise opinion. So pain can exist as a single entity or a comorbidity. So there's a bidirectional association with pain and depression. The pain can come first, but there's always an underlying adjustment symptom or adjustment symptoms. I mean, if you can imagine, if you're in chronic pain, how does that impact you? Not only physically, but also cognitively. So, you can have pathways through pain, like insomnia is very common. There's an abnormal focus on pain. Their thinking becomes very catastrophic, and you can say that they are common neurotransmitters to that. So we need to have a model that incorporates assessment treatment of pain and depression simultaneously. You can't treat one and then the other, or the other way around. And that's very important. So once you're treating the pain, the patient feels, okay, they're being validated and something's being done. At the same time, the depression is being treated. They are working through those cognitive distorted images, and we are focusing on functioning. Well, the pain is getting better, you're sleeping better, we're going to give you treatment so that we can improve your function. So we are teaching them to adapt during that time rather than cause the deconditioning. So, 85% of people with chronic pain are affected by severe depression, as you know, and they have a poor prognosis. So any dual diagnosis has a poor prognosis, and basically sometimes also the drugs that are used for chronic pain can potentiate depression. So it's also important to keep that in mind, especially opiates. They can give you that feeling of enhancement and feeling good, which then increases the risk of abuse and dependence. And when they stop the opiates, they get very depressed. So that's very important. It's a drug-induced depression that gets magnified in the background of vulnerability. Very, very important. Suddenly the drugs are stopped, or the Palexia is stopped, and then they put on Panadol and Panamax, and then you see that they become profoundly depressed. Very important to keep that in mind, that when you're weaning off that group of drugs, that to monitor that and to keep an eye and to inform the patient that there's a high risk that, when they're stopping Panadine Forte or any of those drugs or ketamine infusion, they feel good. And once you stop it, they start getting worse. So that's when the depression will be at its worst. So I've just talked about the, the treatment of depression with pain. As you know, it's quite challenging to treat that. And this is what I was talking about, how the opiates and the benzos, how they can impact. So it's very important when someone comes with pain, you have to keep that in mind, that what drug you're giving, why you're giving it, especially for pain, and that the risk of abuse and dependence is high, given that they may have comorbid depression. So we use certain group of drugs when you have depression and pain. Commonly used drugs are tricyclic antidepressants like NDEP, which is very good for pain and sleep. So if you're not sure with someone, if you're giving someone pain medication, they're not sleeping, and you're worried about some adjustment symptoms, you can give a trial of amitriptyline or NDEP, and it's pretty safe. And it may help with sleep and also help with the depression. Sometimes we now use another one called Cymbalta or duloxetine, very commonly used for nerve pain. And that actually gives a bit of buoyancy. So it helps you with motivation and drive, and that can actually give you a bit of, oomph. So very important that to counteract the effect of the opiates, then we have to give them more antidepressants and work on sleep hygiene and things. And that can be very challenging. Next slide. So this is what I was talking a little bit about PTSD and depression. People say, if you've got PTSD, can you get depression, or can you have comorbidities? PTSD is a condition with comorbidities. PTSD does not exist by its own. It can be prominent, but a lot of them will have generalized anxiety, panic disorder, and depression is very common. So about half the people with PTSD will have major depressive disorder. And basically, they also have marked impairments in terms of high levels of distress and anxiety, and prognosis is very poor. The common thing with PTSD and major depression is they share a number of cognitive and memory processes. And there are a lot of maladaptive cognitions that can make it very hard, because they have a tendency to interpret things in a negative way, catastrophize, and blame themselves. So that becomes a vicious cycle while you're trying to treat both of them. And it can be very frustrating and challenging in clinical practice, because they would be on polypharmacy, on multiple drugs, and gone through things. And generally, you come to a point where you say, look, I need to determine the prognosis now. You don't need to go through all the treatments. Generally, I would say, people say, do EMDR, do these treatments. Sometimes the patients are not conducive to intensive psychotherapy. So if they've had 6 months of intensive treatment in terms of pharmacotherapy and some CBT with some EMDR or not EMDR, you would say, look, they have reached maximum medical benefit, and it's unlikely they would improve unless they do an inpatient program or do the outpatient PTSD to break some of that social inhibition. I'll go to the next slide. So these are just some of the domains of treatment we use, as you know, pharmacotherapy, psychological therapy, different ones. CBT is, of course, the most, we use ECT, and we also starting to use now transmagnetic stimulation. Can we go to the next slide? I'll skip through this slide because it's about indications for antidepressants. And, this is just generally, I put that. So we might skip through some of those slides because it's just side effects. Just to be aware with when you're starting antidepressants or any medications related to mood, you just need to be telling them of the side effects. One of the commonest side effects is sedation and weight gain. That the patient is worn and they've got chronic pain and they've got weight gain. You don't want to give them an antidepressant that causes more weight because they're anyway sedentary. So it's really important that it's very important to understand that. Can we just go to slide 19 for just one before that? Okay, so just that when you give an antidepressant, you need to know the side effects. It needs to be catered to a patient, to their needs and the symptoms, and you need to let them know the side effects. And they need to be monitored very closely, and basically very important in the elderly to watch for hyponatremia. I'll probably go through these very quickly. We won't worry about the discontinuations. Next slide. And the next. So you do not stop antidepressants straight away. So you need to make sure when you're changing, the GPs and others have to be careful. Generally, we are asked, why did you change the antidepressant? What's happening? So in 6 weeks, if an antidepressant is not working, it's time to change or add or work through that, because that's very important to, and the patient needs to be warned. So I'll move through this. So I've just written a list which you can grab a copy from the slides as to which antidepressant is good for what and why do we use that particular one. So that is something symptom derived, and sometimes to the GPs I'd say try this because it has been proven that it affects. Go to the next slide. So I'm sure we're all familiar with cognitive behavioral therapy. It's very important to let know. So we are working with behaviors, thoughts, and emotions, and this starts early on. This is where I'm coming on. When someone presents with depression, we are working with behaviors. We are working with physical feelings to prevent the thought, and we're removing them from the situation so they can work with that. And that's really important. That's a very important part of emotional regulation. You show behaviors first, you show physical symptoms first, last are your thoughts to come, and they're the last. So when you're treating someone, what do you expect? I usually would say the first to go are the physical symptoms. Your sleep, appetite, concentration will get better. Then your behaviors will change by doing goal setting. And the last to change are your thoughts. And that's why it takes a period of 3 to 6 months of treatment to get that change, because thoughts are last to change and medications do not change that. So it's very important to tell them what does medication do, why you're having cognitive behavioral therapy, and what to expect. So the time frames are very important. Up to 12 weeks usually is the time frame for medication assessment. Start someone medication, review them in 4 weeks. 16 weeks is where, if it's the right medication, then the response will be obtained in terms of behavior and physical feelings. At the same time, you're working with thoughts and goal setting to decrease that cognitive thinking. Okay, next slide. I've just put that in because we all have to deal with self-harm and suicide thoughts. And generally, this is when hell breaks for everyone. When a patient says, I'm acutely suicidal, or I'm having thoughts of hurting, or I'm cutting myself. So that's really important that we just need to work a crisis plan, very important. So as is, we said, seek help from your doctor, mental health team, we give them emergency lines. And these are some, helplines which can be very helpful to give it to the patients when they come with depression. I usually give them always in the first or second session, say you may not need it, but just keep that in mind and just go through a brief crisis support plan. Who are your main support? Whom can you reach after us? What help can you get? And what is expected? So that actually prepares them and helps them a little bit. Next slide. So this is something we incorporate. We talk a lot about mindfulness. It's the big thing. You should do mindfulness. It's very broad. When you ask patients, what do you mean by mindfulness? They have no idea. Oh, my psychologist said, go and do some breathing, and that's mindfulness. Not really. So we talk about what is mindfulness. There are different kinds of mindfulness. You could do a breathing, you could do a mindful walking, you could do a mindful exercise. That is the crux for stress management. And we talk about what is the advantage. So it actually helps you to handle distress. So you will only do mindfulness when you're distressed. So you learn how to soothe, you learn how to regulate your emotions, and you're more interpersonally effective. And there's a lot of evidence and data to provide that. But it has to be done in the right manner, and it has to be implemented really early on through different channels, through an exercise goal. Having an exercise physiologist is a really very important integral part for someone who's depressed, who's got chronic pain. Start that physical activity earlier. Seeing a psychologist, working out a daily routine, sleep hygiene plan, having 3 mindfulness strategies, so important. I cannot emphasize that. I usually say your drug's only 20 to 30%. 70% is stress management, environment, and working through these skills. And that will lead to an amazing outcome. Yes, it does take time. Yes, there are barriers, but with the barriers, we work through that. So the main barriers could be, as I said, is chronic pain. It could be personality factors. It could be ongoing stress. So there could be ongoing stressors, whether it's work stressor, financial stressors, relationship stressors. You're teaching them to muffle that and focus on their self, and that leads to a really good outcome. And the last bit, I'm going to talk a little bit about transmagnetic stimulation. Now, this is now a new novel therapy. I've had patients who have had transmagnetic stimulation over the years, but never emphasized or paid attention till a few of them gave feedback how effective it was and how much it was helping them. And that led me to do training in transmagnetic stimulation and working. So there has been basically a lot of dilemmas about the effectiveness, and Medicare has now approved it last year because there's now evidence to prove it's one of the non-invasive therapy. So I use it in my rooms. I've got transmagnetic stimulation in my rooms, and I've started to use it for some of my patients. So there is a criteria. It is used for treatment-resistant depression where 2 antidepressants have failed. Again, we implement a treatment early on. We do not wait for things to get worse. So a patient has had 2 or 3 antidepressants, they're still showing signs of depression, irrespective of the cause of depression, whether it's a physical, whether it's work-related or situational. I will put them, say, look, why don't you give a course of transmagnetic stimulation? So what it does is it induces a magnetic field in your brain, which helps to improve depression. So it's based on the hypothesis that in depression, certain parts of your prefrontal lobe are hypoactive, and by giving a magnetic field, it stimulates it. It is a good alternative to ECT because a lot of people don't want ECT. You have to be in hospital, B, it causes memory problems, while transmagnetic is done in the rooms. You have sessions twice to 3 times a week. They come for 20 minutes. I do the mapping for the mean resistance. There's also another psychiatrist who works with me, and we go through the criteria as to when they can have. Of course, you can't, if you have any clips in your brain, you've had cochlear implants, or you've had a pacemaker, you can't, or epilepsy. But other than that, it really helps. When someone is coming 2 to 3 times a week for this therapy, this with psychotherapy seems to work very well. And usually the feedback from some of my patients who've had PTSD, being police officers, they have come back. They've had a year of that, and they've said, look, it's helped me with my motivation drive. I've gone back to work. I still have depression, but I feel much better in the anxiety. So that's a really good outcome. It doesn't cure you, but it gives you some leverage to get your function back. And again, the side effects can have a bit of headache and TMJ joint function, clicking, but on that it's pretty safe. So usually 20 to 25 sessions, and you will need sometimes ongoing sessions. So I find that if there's evidence, now we are getting approval for treatment, and it's really good that the patients are starting this journey because it's quite helpful. So I'll just go through the next slide. So this is just what we're talking about, TMS and how it's helping, what are the side effects with antidepressants, with ECT and the TMS, and you can see that it has a very good side effect profile. And I thought just run on the next slide. So then you can see that how it's got a 37% rate of recovery. So that's pretty good compared to 50% reduction in science. All right, so what are the factors that determine recovery, prognosis, and function? So as we've talked about throughout the slides, early interventions, good prognosis, very important to eliminate stress or remove them from the stressful effect till they can get treatment and then re-engage them back. So one of the things in psychiatry is people, we rehabilitate them vocationally because it is directly related to their well-being. But the vocational rehabilitation has to be done at the appropriate time, and it has to be graded, keeping in mind they're not put back in the stressful situation. That's really important. If you want someone to recover, it has to be graded, it has to be slow, and you're not with a good support, and they perhaps do very well. Now, the rehabilitation can take 4 to 6 months, but it has to be appropriate, time limited, and good recovery. Again, comorbid factors are very important. So if there is ongoing work stress, financial stress, chronic pain, that can skew the recovery, and then someone will be partially incapacitated or partially capacitated. And that's sometimes timeframes cannot be assessed, but you can give them some direction. This is where this patient is going to go. Personality factors can determine their future prognosis and functioning. So if someone has got some personality factors like they have obsessional personality or they have a dependent personality style, they're likely to cope with stress poorly, and they can lead to more problems. High expressed emotion environment, this is what we're talking about. If patients are placed in hostile environment or put into highly conflictual environments while they're recovering, the prognosis is pretty poor and they will relapse despite treatment. And there's been a lot of studies to show that despite intensive treatment, if you're put into that challenging environment, you will relapse. And then again, your recovery is only 30%. And basically, you have a very poor prognosis. We talked about exercise physiologists. They're a really important part because a lot of them don't exercise. You can send them to the gym, but I find that really helps with the social factor. It gets you out of the house. It gives you confidence. It gives you physical exercise, and it gives you a goal, a timed goal to see assess. And of course, supportive and interpersonal therapy can be very helpful. Okay, that's all I have to say. Don't worry about the case. I just put it. I was just trying to keep it in mind the time. So I had about half an hour, and I'll probably try to finish that. So anybody has got questions?
Yeah, thank you, Dr. Rastogi, for the presentation. If anyone has questions, please come forward and unmute yourself so you can ask. Yep, so I guess no one has any questions. If anyone has, please come forward. Yes, I guess the presentation must have been very informative. So probably you have answered everyone's questions already. So thank you.
Can I just ask one question?
Oh, yeah.
With a patient that you don't know very well, do you get concerned that the presentation of depression might be due to an underlying significant medical problem like hypothyroidism, brain tumor, dementia, etc.? And if so, do you investigate them yourself? Should a GP or a psychiatrist investigate them, or should they all be seen by a neurologist? How do you handle that as a general psychiatrist?
You're talking about in terms of, say, you're saying when you're assessing a patient for the first time?
Yeah.
Yeah, look, I usually will write to a GP. My first letter always says, can you please do baseline tests? I will always ask them to run a basic thyroid function test, full blood count uses. That is a baseline because that's also needed for medications, because some of the medications can interfere with liver function tests. So that is something I will always ask you, can you please organize these baseline tests to start with? And then, of course, if it's specific, someone's got severe headaches or they have chronic headaches, then I'd say it would not hurt just to have a scan done just to rule out an organic cause. But that's the baseline. We get metabolic parameters, and baseline blood test is something I usually get all my patients. And patients who are known for a while, I will tell them every 6 months, if you're on medications that increase your metabolic profiles, make sure you get those tests done. So I write down to the GP very often.
Do you MRI everybody, or?
No, you can't do MRI in everyone because MRI is very specific. As I said, if they have chronic headaches for about 1 or 2 years and they have got some symptoms like blurred vision, or they're having very unusual non-specific symptoms, it's different to having stress-related headaches to compare. If they have physical issues like neck issues or disc, that is something the GP does that I would say, I leave it to the expertise of the GP. But if they have got chronic migraines, they've got an aura, if for 2 years, they've got blurred vision, they've got concentration problems, I would say it would be prudent to do just an MRI, and if there's any abnormality, to see a neurologist. But I'd leave it to their opinion, to their expertise.
Thank you.
Yep, thank you. Does anyone else have any other questions? So I think Olivia actually brought something in the chat. So what are your thoughts on psychometric testing by a psychologist to help diagnose a patient?
Look, psychometric testings is very important. Some of them are quite reliable and valid. Some of them are self-reported, and they do provide basically an assessment in terms of the impairment, and also to see whether the symptoms are uniform or not fluctuating. So there are a lot, of course, most of the self-reported scales we do, like DAS, can be quite skewed because it's self-reported. However, I tend to do the HAM-D or the Hamilton scale, or that is basically a clinician directed, and I think they have a place in terms of seeking the validity, in terms when somebody is not responding to treatment, then you would say, hang on, what is happening? Is this self-directed? Is there a secondary gain, or there's any malingering, or are we missing something in terms of diagnosis? So they do play an important part in diagnosing personality factors, coping styles, in terms of functional prognosis, and sometimes in times of malingering. They do play an important part. And when the symptoms are disproportionate to the stressor.
Yep, thank you, Dr. Rastogi. So we don't have any other questions in the chat. So final round, does anyone still have any questions? So if not, I'd like to say thank you, Dr. Rastogi, for a wonderful and informative presentation. And thank you, the participants today as well. So I guess our presentation will end here. And I hope to see you all in the next seminar. Thank you, Dr. Rastogi.
Thank you so much. Thank you everyone for attending. I hope it was useful. Take care.
Thank you.
Bye.
Bye.